The COVID-19 pandemic has affected everything in every walk of life. It's difficult to go anywhere without it being front and center and everyone aware of it. It certainly affected our practice. As many physicians had to do, we had to do a 180-degree pivot to address this, not only the patients coming in to the hospital, but also trying to take care of our patients with interstitial lung disease on the outside. These patients have a lot of requirements. We typically will see them at least every 3 months. And when our hospital was pretty much on lockdown with the initial surge, we weren't able to bring patients into the hospital. We're doing a lot of Zoom visits or telemedicine visits. We still do quite a few, not as many as we did in the early days of the pandemic. And we've been able to manage our patients as best we can through the pandemic that way. Now we're starting to see them in the clinic. I'd say probably 80% of my visits now are in person, 20% are Zoom. But it's a little bit of a silver lining, the telemedicine aspect, because there are patients who are much more suited to telemedicine visits. For example, if I have a patient who lives 4 hours away, then sometimes we'll just check in via telemedicine, make sure they're doing okay, rather than them taking the whole day, having an 8-hour drive, getting stuck in traffic to come and see me, when I know just by visiting them in their home via telemedicine, I can tell that they're doing okay and there's not going to be anything that I'm going to change. I think that COVID has also resulted in increased discovery of interstitial lung disease because, as I mentioned previously, there are a lot of asymptomatic patients who are out and about, walking about, don't know that they have an element of ILD. But when you get COVID and you get chest imaging, specifically a chest CT scan, not only can you pick up changes from the COVID pneumonitis, but you can also have an appreciation that the patient might have an element of interstitial lung disease that was previously undiagnosed. One of the things that we know about ILD and IPF in particular is that it is accompanied by an increased predilection for certain comorbidities. Even if you take into account other risk factors and age, patients with IPF, for example, have a higher incidence or prevalence of coronary artery disease, obstructive sleep apnea, gastroesophageal reflux disease, pulmonary embolism, thromboembolic disease, even diabetes. So in terms of taking care of these patients and providing holistic care for these patients, it's important to be aware of these comorbidities and to be on the lookout for them, to be preemptive and try and manage them. And because sometimes patients will die with their IPF rather than from their IPF. A good example being coronary artery disease. If it goes undiagnosed, patients can have an event that they can succumb to. So it's important to be aware of these comorbidities, to screen for them and to address them when you find them.